Hi, everyone. All right, so we are going to be getting into the elbow, and we're also going to be doing the forearm a little bit here in this lecture today. So we're going to look at the anatomy of the elbow and how all that works. Now, when we talked about the shoulder last week, one of the things that we did discuss is how the shoulder is so incredibly mobile. Right, we said that it had 8 different active motions that it could do, 9 if you count circumduction, which yes is a combination of a bunch of different ones. But we had a bunch of different motions that we were able to discuss, and all the different muscles that were kind of helped in terms of the way that the shoulder was actually able to move. Right. So in this class, a few times we've talked about this notion of stability versus mobility. Right, and if you have a really mobile joint, it's usually not all that stable. But if you have a really stable joint, it's usually not nearly as mobile. And that kind of goes along for the elbow as well. Whereas we had 8 motions with the shoulder, the elbow really only has 2 active motions. In that sense, it's kind of similar to the knee, right? It really can only flex and extend. So you're going to see that we're going to discuss a little bit more about the bony structure and everything like that of the elbow, how that all functions, and how that differs a touch from the shoulder that we discussed last week. So, getting into it, we talk about the anatomy of the elbow, right? The elbow joint itself consists of 3 different bones. It's an articulation between the humerus, the ulna, and the radius, right? The humerus, of course, we know is our upper arm bone, and the radius and the ulna are the 2 bones in our forearm, right? So when we actually talk about the elbow joint itself, I believe, when we actually talk about the elbow joint itself, you can see that the elbow. The main elbow joint that we see is an articulation mainly between the humerus, which you can see is up at the top of this picture here, and the ulna, which is once again one of those bones in the forearm. So we're going to get into the bony anatomy of the forearm a little bit later in this video, but for now we want to just talk mainly about that articulation. As you can see from this picture, the head of the radius is also present. It does have a bit of an articulation, but in terms of the stability and really the motion of the elbow joint, we're looking more so at the articulation once again between the humerus and the ulna. And because of that, as we all know, we can talk about the actual name of the joint, which in this case is the humeral ulnar joint, right? When we're discussing the elbow specifically, usually we'd be referring mainly to the humeral ulnar joint. The radial humeral joint does have an articulation as well here, so once again that is part of the elbow, but you'll see as we get down next week into the hand and to the wrist that there's going to be a little bit of a difference, right? The ulna is going to be much more active in the elbow, and the radius is going to be much more active in the wrist. So like I said, together these joints, they have 2 separate motions to them. They have flexion and extension, and that's really it. So when we take a look at this, we want to think about how this range of motion actually works. And this is true for pretty much any joint, right? We have this idea of what we call an end feel. So when we're doing any sort of range of motion testing in sports medicine or anything like that, we want to know generally how much range of motion we should expect to have. And once we get to the end of that range of motion, we want to think about how much or what is really stopping that range from continuing. So as you can see in this picture, right, with elbow flexion, see if I can get myself in my camera here, with elbow flexion, we're just trying to bend our elbow as much as possible here. And as you can see, I mean, the numbers for this particular class don't matter as much. Like, that's more of a sports injuries or strength and conditioning style question there. But you can see that, it bends to about a 150-degree angle. Nothing, it doesn't go, too far. I mean, I doubt that anyone would really ever have the ability to go beyond, 150, 160 degrees, because we get to what that end feel is, right? So in flexion, we get what we call a soft end feel, right? Because the thing that's actually limiting us from getting further into flexion is our bicep, right? Our muscle actually gets in the way. Some people might have really tight triceps, which would prevent them from flexing their elbow more so. But for the most part, if you have relatively healthy and flexible triceps, then what's actually going to get in the way is your bicep rather than any other bone or anything like that. So it's, always kind of funny to think about that, people who are very strong, that have very large biceps, we think about like Dwayne "The Rock" Johnson, right? Like, the one thing that I have over him is the fact that I can bend my elbow farther. So yay me. But when we think about these sorts of things, we want to think about the other side of it as well. So extension, we see, should be about 0 degrees. We'll get into the idea of hyperextension here in a minute, but we should think about, like, you know, the 0 degree marker, meaning that it is, you know, just as the same way that we would see it being in anatomical position. Just going to angle myself in the camera screen right here. You can kind of see that, you know, the arm just really, you know, goes, it should just really fully be straight. And if you were to go into that range of motion, or if you were to do that on somebody else, you would notice that unlike the kind of squishy, springy feeling that happens with a soft end feel, we have what now we call a hard end feel. And that really is the bones knocking into one another, right? And we're going to get into what those bones are here in just a minute. But yeah, the bones are actually going to go in, they're going to click into place. Hopefully not click, I guess they're just going to slide into place, and that's going to give us that hard end feel that shows us that we are at the end of our range of motion. Can't really push very much further because there's no tissue that you're stretching out or anything. It's just the bones that are hitting one another as it is. Now, when we get into hyperextension, and actually I'm gonna go back to this slide just one second. I want to go to this slide to start off with here because we talk about what that hard end feel really is, right? On this picture here, you can see a couple of different X-rays, and in every one of these pictures, we see at the top of these pictures is the humerus. And at the bottom of these pictures is the ulna and or the radius, depending on the one that we're looking at. So we can see, we're going to look at the blue arrow right here first. We see the blue arrow is kind of pointing to that part of the bone. That is the ulna that we're taking a look at right there. Part of the bone that's kind of like hooked around. And when we see that that bone is starting to hook around, that hook that we see is something that we call the olecranon process. And we'll get into, you'll see that on the screen coming up in a little bit. But yeah, the olecranon process is on the ulna and it kind of sticks off of the back. That's, you know, if you feel on your elbow, that bone that kind of sticks out right there, that is the olecranon process that's on the ulna, right? Then we can see on the red arrow here, we see a little divot. You can kind of see a little hole in that X-ray that is on the humerus. So the olecranon process plugs into the olecranon fossa. So when we have those alignments, when the process plugs into the fossa and we have this really stable articulation, we get a few different things. Number one, we do get that hard end feel that we were just talking about, right? And that's definitely something that's going to stop us getting any further into extension because, again, it is quite literally bone on bone, right? But in addition to that, one of the things that we have that's really special about our elbow is as we lock out our elbow, it is a really, really stable joint. We can see, if we go back a few slides here, we can see the shape of this joint. We see the trochlear notch of the ulna goes into the trochlea. Now that's essentially just two kind of curved surfaces that kind of, you know, are perfectly shaped for one another, that kind of, you know, are able to nice and smoothly kind of glide in that area, right? And we can see that because of this really nice shape of all of these bones, in addition to the olecranon process and the olecranon fossa on the posterior side of the elbow, that we get this really good stable joint, right? If I bend my elbow, I can start to kind of move it around in you know, any which way. It's a little difficult to do at this angle, but you know, you have a little bit of play in your elbow. It can kind of move you know, from side to side, just like the knee was able to move into varus and valgus. The same thing is possible with the elbow when it is when it's a little bit flexed. It's really, you know, it's kind of unpacked. But the moment that you lock everything into place, now that joint is significantly more stable thanks to the shapes of the bones and the presence of things like the olecranon process and the olecranon fossa. So looking into all of these things, we want to see, once again, as that process plugs into the fossa, that is what stops extension from happening. Now, for some people, we can see right here that certain people have the ability to get into elbow hyperextension, right? Now, if you are just kind of naturally, you know, some people have this, they're able to extend their elbow beyond. You can kind of see the picture. It's the picture right here with the red X on it, right? Like it's not necessarily the best idea to continue to hyperextend your elbow joints because you can see right here it places a decent amount of extra stress on the biceps. Definitely not, you know, if you're able to do it, might not be the best party trick for you by any stretch, but, you know, it's definitely something that we can kind of, you know, we can see that certain people have the ability to do. We take a look at, again, some more x-ray pictures, and we can see on one side here, we have a normal bone that, has the olecranon process sticking off the back of the ulna, once again. And then we have, you can even actually see a little bit of the divot right on the distal end of the humerus where the olecranon fossa sits. Once again, they kind of plug into one another. The people who are able to do this level of hyperextension, they'll actually have either a smaller olecranon process or a deeper olecranon fossa. So they're still getting that hard end feel when they're getting into full extension. You can kind of see certain people will just kind of let their arms hang to get into that kind of hyperextension range. You still see that those people have that same hard end feel. It just ends up going further. And now because of that, once again, they kind of have to stretch out their biceps a little bit more, and that's where that idea of hypermobility comes into play. So when you get elbow hyperextension as a result of like an anatomical difference that your body has versus what we would consider to be, typical in most others, then that's something that we call cubital recurvatum. And that is essentially just a very fancy Latin way of being able to say that we have elbow hyperextension, right? We've all heard of, we might not have heard before, but if you've ever, had like your blood drawn or your blood pressure taken, the little section right here in the front part of your elbow, that's what we call the cubital fossa, right? So cubital kind of refers to the elbow region of our body, and recurvatum is talking about hyperextension. So this would be, again, that kind of representation of that cubital recurvatum, especially, again, we see that picture with the X in the bottom corner. Now, under that picture with the X in the bottom corner, we have the other type of elbow hyperextension, which is significantly worse. We can hyperextend our elbow. Usually it's a result of a pretty significant injury, maybe kind of falling backwards, while you're trying to brace yourself in the back, doing something like that. In those times, you might end up fracturing your olecranon process, right? You might even, as you can see, sometimes it actually fully breaks off of the rest of the ulna. Well, now you'll be able to hyperextend your elbow quite a bit, but obviously that's not necessarily ideal, right? Broken bones, they'd probably have to put some pins in there or something like that, or put a rod through to kind of get that normal elbow functioning back. So, we can see that happens as a result of an injury, but we would imagine that that's a less common case than when we see somebody with that, kind of natural hyperextension that once again is called cubital recurvatum. Anyway, moving on from there, we talk about the bony anatomy, and again, we talk about these really unique structures that allow us to have, especially in full extension, that allow us to have that really nice, stable elbow joint. It's one of the reasons why it's so much easier, if you're like holding something over your head, so much easier to fully extend your arms, because now you have, just a full weight kind of coming through, just through the bones themselves, and you have the ability to lock out and get that unique structural stability of the elbow. But of course, whenever we have this, now we have to rely a lot on ligaments to be able to make sure that, we have flexion and extension stability, but now we want to make sure that on the sides of those joints that we're also having some really good stability there too. So when we talked into the knee, when we were working with the knee, we were talking about the fact that the knee has the capability of performing flexion and extension actively. And then remember, we called them passive movements, but those were the varus and the valgus. And that is the same thing that we can see here in the elbow, that our elbow can actively flex or extend. Just trying to get in camera here. Elbow can actively flex or extend. It absolutely has the capability of doing either of those, but what it also can do passively is kind of enter into this varus or valgus. It is much more difficult to do so, once again, when our elbow is fully extended, but it is still technically possible, so we of course have to rely on these ligaments. And in the same way that they were called the ligaments that kind of wrapped around the side of the knees, remember that those were called collateral ligaments. We had the medial and the lateral collateral ligaments. So we still have collateral ligaments in our elbow because in the anatomical position, they kind of run along the same aspects of the body as the collateral ligaments in the knee do. The only difference is we're not going to call them medial and lateral collateral ligaments here because that would get very confusing as to which one you're talking about. But instead, we call them radial or ulnar collateral ligaments, depending on which side of the forearm those ligaments run. So a really silly mnemonic that I learned in college that always kind of helped me out is when we think about the radius in the ulna in our forearm, right? We want to see, well, which side is on which. I always thought of what I learned is, thumbs up for rad, right? Yeah, it's rad, right? So radial is on the same side as your thumb, right? So I don't know. To me, that made sense. That probably sounds ridiculous to you, but that's one of the things that helped out for me. However you want to kind of learn which one is which, we know then that in the anatomical position, our thumb is one of the most lateral parts of the body, really, in the anatomical position. So we know that the lateral collateral ligament of the elbow would be the radial collateral ligament instead, because the radius is on the lateral side of the body. And the same thing can be said about the ulnar collateral ligament. That's on the medial side of our forearm, and therefore our arm in general. So our ulnar collateral ligament provides medial support. Right. So when we think about that, in this particular situation, we can see, we have the RCL and we have the UCL. Both of these things help to prevent varus and valgus, and we want to make sure that we're looking at which one does which. So when we see the lower arm angling back toward the body, I believe I might have a picture of that. No, unfortunately, I don't have a picture of that one right here. I'll upload a picture of that into Canvas as well, so you guys can see that. But we talk about something called the elbow carrying angle, where what we can see is whenever we have varus, our elbow kind of, as we hold our arm out to our side, our lower arm, our forearm, kind of angles back in toward our bodies, right? And, so it kind of looks like a similar alignment as varus does in the knee, right? Where the joint itself starts to move a little bit more laterally. Now, in valgus, just like knee valgus, it was kind of like knock-kneed, like the knee joints themselves started to move a little bit more medially. The same thing would be the case here for valgus alignment of our elbows, right? And that would mean that our forearm actually angles a little bit too far laterally toward the outside, moves too far away from the body. So when we take a look at that, what we would say is that the radial collateral ligament helps to prevent any extra varus forces from happening. And then the ulnar collateral ligament helps with any level of valgus that would happen. And in the same way, again, MCL would protect against valgus in the knee, LCL would protect against varus in the knee. The exact same thing happens here. We're just calling the CLs, the collateral ligaments, something different to help us differentiate. If anybody's a baseball fan, you might have heard of the UCL before. The UCL is kind of infamous in baseball, right? And the reason for that, we can see right here, I have the red arrow kind of pointing to that shadow in that guy's arm. Yeah, that shouldn't be there, right? That excessive strain that he is getting is because his UCL is really lengthened. If you imagine just kind of pulling on a rubber band over and over and over again, you eventually see some little micro tears that begin to form on throughout that rubber band, right? And the rubber band itself actually ends up staying slightly longer than it did before. The exact same thing happens in the body, right? Our body has the capability of healing, but if you continuously stretch out that ligament over and over again, the body will stop attempting to shorten it back up and just kind of cement it, just kind of repair it in place in that longer position. So a lot of times what happens is that pitchers don't have to get UCL surgeries or UCL replacements because they've completely torn their UCL. It does happen. But the more common situation is that they've stretched out that ligament so far that now they just have none of that stability left in their arm. Again, that UCL, as you can kind of see, this is a pretty damn good example of a valgus alignment of the elbow in general anyway, right? The UCL should be preventing him from getting into that much valgus during this pitch. So if that UCL stretches out over time, over and over and over and over and over again, and we start to see a lot more of these gaps that, like we can see, is kind of created by that shadow in his elbow right there, that starts to require surgery. And that's pretty famously known in baseball as a Tommy John surgery. He was the first athlete to have gotten this, so I guess he got the pleasure of having it named after him. But at least I think he's one of the first. I don't know if he was the first, but it's. Yeah, so the UCL, if it stretches out over time, they have to go back in there and either replace it or tighten it back up. and that ends up giving the pitcher a little bit more time. But we're going to talk a little bit more, especially when we're meeting back in class, talking about like the strengthening basics and all that kind of stuff at the end of the semester. We're going to talk a little bit more about possible ways that we can help to prevent this kind of thing from happening, right? We want to think about, well, why is this happening in the first place? And, you know, if we can do anything besides just telling him stop pitching, right? What else can we do to be able to do that? So, again, we take a look at this, and we want to obviously try to avoid having people drill into bones and cut open skin and stuff like that. So if we can avoid surgeries, we should probably do so. So we'll talk about that again as we're kind of getting closer there. Moving on. We want to talk about the muscles that control the elbow specifically, right? And again, as I was saying before, with the shoulder, there were a decent amount of muscles that would actually help to control all the different motions that the shoulder has. That is not necessarily true when we're talking specifically about the elbow muscles. Now you'll see, especially when we talk about the forearm, and especially once we get into the wrist and hand, we're going to see that there are several muscles that cross over multiple joints, to be able to help flex the elbow or extend the elbow as well. But when we talk about the actual main elbow muscles, the ones that really tend to work specifically on the elbow, the ones that we're talking about are pretty much just divided into two different, compartments that we've talked about in the past, right? We have the muscles on the anterior side of the body, and then we have the muscles on the posterior side of the body. So again, even before I move on to looking at any other slide or anything like that, if we're standing in the anatomical position, we can kind of see, moving the screen here, we can kind of see, the muscles on the anterior side of the body. We've already talked about the fact that when a muscle contracts, it's always going to shorten, and it's going to do its best to try to pull the insertion back toward the origin, right? So, whenever a muscle pulls, a muscle on the anterior side is more than likely going to flex the elbow. Right? And then muscles on the posterior side of the arm, those are going to be the ones that extend the elbow. Now, most people already know about the main movers here. We're going to get into those in just a second, but you can pretty much already predict which muscles are going to do which in this particular case. But we'll talk about both the main movers and maybe some of the synergists throughout this lecture as well. Before we get to there, though, we want to talk about the fact that, as I was just saying, when a muscle crosses several joints, we've talked about this a lot in class already, but when a muscle crosses several joints, it's going to act on every one of those joints. Right, so we see that, for example, the biceps, we'll get into the forearm aspect of this a little bit later on, but we can see that the biceps absolutely crosses the elbow, right? So, of course, it's going to work on the elbow. But if you take a look at this picture, and we'll get a little bit clearer of a picture as well a little bit later on, but you can especially see the muscle that's highlighted in yellow there. That's what we call the long head of the biceps. As that muscle crosses over the shoulder, we can see that it actually attaches, both heads of the bicep actually attach onto the scapula, meaning that they go from the elbow, they cross over the elbow joint, but then they don't attach onto the humerus. They actually move up over the shoulder and attach onto the scapula as well. So that means that it crosses the glenohumeral joint, and as such, it works on the glenohumeral joint. So once again, we talked about it last week. If there is a muscle on the anterior side of the body that we know works on the shoulder, chances are it has the ability to flex the shoulder as well. So the bicep not only flexes the elbow, but it also flexes the shoulder. And it actually has a couple of other motions too, but we'll get into those a little bit later on. But yeah, so when we're talking about these things, we want to think about the notion that we have muscles, when they cross multiple joints, they perform multiple actions. And we can start to harness this in ways that maybe help to advantage that muscle, to give it that mechanical advantage that we've talked about a few times in class, or maybe to disadvantage the muscle. Maybe we want to put it on a stretch and make it a little bit more difficult for that muscle to actually do its job. So we'll move into that a little bit more, but I just wanted to make sure that everybody understood, especially as we're moving into the hand and forearm, the hand, wrist, and forearm, I should say, those muscles cross a bunch of joints, and they are going to work on each and every one of them. So we'll move into that a little bit more. When we talk about the elbow flexors, again, the anterior side of the body, we are going to be talking about the main movers, which are, of course, the biceps. We'll show you the graph of that in a second. But then we also have a couple of other ones, brachialis and brachioradialis, that are, more synergist, but they absolutely still do help with elbow flexion. So looking into the biceps, of course, the word biceps in general means two heads. And as we can see here, we're seeing the label of the long head versus the short head. Now, when we talked about the shoulder, and you can go back and look at the slides that I have posted up for the shoulder, we talked about the shoulder, we talked about on the toward the head of the humerus, we had the greater tubercle and the lesser tuberosity that were up toward the top there. And you can even see in both of these pictures, you can see those two pretty well highlighted right toward pretty much the most proximal end of the humerus, right? And in between two of those, we talked about the inner tubercular groove, right? So that inner tubercular, well, I cannot say that word, my apologies, groove, that's where we can kind of see we see the long head of the biceps running right up through there. So whenever we kind of feel right in that area, you know, especially if you have what we call biceps tendonitis or biceps tendinopathy in any way, you know, you'll be able to kind of feel right where that long head of the biceps tendon kind of runs up right through that little notch that sits right there, and it gets and it passes through to attach onto the scapula. But once again, as we were talking about before, we can see that the origin points are up on the scapula. The insertion point is actually down on the radial tuberosity, which is of course on the radius itself. So we have flexion of the elbow, we have flexion of the shoulder, and we also have supination. And we're going to get into what supination is here in just a minute. We haven't that's going to be more in like the forearm conversation. So we'll get to that in just a little bit. But you know, this is what we would consider really to be the main mover of the elbow, or at least a flexion in the elbow, which is the biceps brachii. And I just wanted to point out really quick, we have another biceps in our body that we've already talked about, and this is why I always like to use like the full names of these muscles so that we know exactly what we're discussing, because we had the biceps femoris down in the hamstrings, right? So that's just another muscle that just has two heads, but that one runs along the femur. This one, the biceps brachii, brachia in any form in that sense, is referring to the arm. So anytime we're talking about that, you know, we're talking specifically mostly about the upper arm, kind of like the humeral area. That's what we consider to be like the brachial aspect of our body. We have things like the brachial artery and brachial nerves and all these kind of things. Brachioplexus, brachioradialis, like there's a bunch of different ways that we describe that, and that's all talking about the upper arm. So when we see biceps brachii, we know that that's the one, the biceps that sits in the upper arm. In addition to that, we have the brachialis, again, talking about that, and we have the brachioradialis. Now, when we take a look at both of these muscles, one of the things that we can note right away is that they both originate on the humerus, right? They do not get all the way up above the the shoulder joint. They do not attach onto the scapula or any other part of the arm, or the trunk, I should say. So we know that these muscles are not going to work on the shoulder. But we do see that once again they cross over the elbow joint, so they definitely do help out with at least elbow flexion, especially in the case of the brachialis, right? We can see that the brachialis is pretty much only done for elbow flexion. It doesn't even attach onto the radial tuberosity. It attaches right onto the ulna, so you pretty much just get straight line flexion just from this muscle. Now it's much smaller. It is significantly less powerful than the biceps. So the brachialis, at least in my opinion, is pretty much one of the most specific examples that we can get of a synergist muscle. It's a muscle that kind of helps to smooth out the motion. It helps out to just perform the motion in general, but it's absolutely not the agonist, right? So, you know, we can absolutely talk a little bit more about that once again when we get into the training section of our course here. But for the most part here, when we're taking a look at this, the brachialis itself is one of the muscles that pretty much only does elbow flexion. Now, we get into the brachioradialis here. And now this one, you can kind of see it attaches onto the humerus, and it moves down into onto the really tip of the radius, right? So it doesn't have it listed on here, but we can definitely see that, you know, when you do like hammer curls and things like that, this muscle will absolutely, if your body's in the right position, it will help to flex the elbow as well. But as you can see, it does have the capability of performing either pronation or supination. Again, we haven't gotten into those motions just yet, but what we did talk about last week is when a muscle has a relatively large origin point and a really tiny insertion point, like what we're seeing right here, the fibers of those muscles kind of fan out, right? They start off really wide and they kind of, I guess fan inward really toward the insertion point. Because of that, depending on which fibers are active, at that particular motion, it can help out with opposite motions. We kind of saw that with the trapezius, for example, where it can perform both scapular elevation and scapular depression. So when we take a look at something like the brachioradialis, it does have not only the ability to help flex the elbow, but it also has the capability of performing both pronation and supination, depending on which direction, which fibers are really active at that time. And really, in terms of elbow flexion, that's about it. Right? We don't really have very many. Like I said, there's not a lot of active muscles in this particular case because we don't have nearly as many motions as we did in the shoulder. So we have the biceps brachii, the brachialis, and the brachioradialis. Now, we do have more muscle that assist with elbow flexion, but we're going to get into those next week when we talk about the wrist and the hand. Because that's where we're really going to see that there's a lot more muscles that do cross the elbow joint on the anterior side of the body, and as a result, they will help to flex the elbow. But like I said, those are more like, we would consider those to be like the forearm muscles, but really they're the muscles that help to control the wrist and hand. So we're going to get into those in that lecture. But for the muscles that specifically work on the elbow, or at least majorly work on the elbow, it's really just those three. And the list actually gets even shorter when we think about the elbow extensors, right? The muscles now that we're looking at on the posterior side of the body. Now, I'm sure that every single one of you watching is already going to know what the main mover is. We got a picture of it right here anyway. We know what the main mover of these of elbow extension is, and that is, of course, the triceps, right? And if we said, triceps brachii, because I want to be specific about that too, right? So when we look at the triceps brachii, we think to ourselves, well, how many heads are there? Triceps, there's 3 of them, right? And as we take a look at this picture right here, we can see three very distinct origin points, right? So we have a medial head, a lateral head, and a long head. I don't know why they named them the way they did, but I mean, I guess the long is the longest of them, so there you go. It's a little simply named, but we'll take it. When we take a look at the origin points, though, we can see that there is one, the medial head, actually attaches really far down on the humerus, and parts of the medial head fibers are really, really short. Because they're only they're only going very small distance over the elbow joint there. By the way, take a look at the insertion point really quick. We can see that is at the olecranon process of the ulna. So we can really see a great picture of the olecranon process here as well. And of course, as we're working with that, we can see exactly why, as it pulls on that lever of the olecranon process, it performs the motion that it does. So we have the origin point of the medial head, which is really pretty far distal on the humerus, and then much more proximally we have the lateral head, and that is more like the upper part of the humerus as well. But then the big one that I want to talk about is the long head, and once again, look at where the long head attaches. Long head attaches, or it originates, I should say, on the scapula. So once again, now we're seeing yet another muscle that technically crosses another joint. So the triceps, the medial head and the lateral head, all they can do is help to extend the elbow. That's they only run over one joint, they only have one action. But when we take a look at the long head of the triceps, that muscle now runs from the olecranon process, crosses the elbow, and attaches onto the scapula, meaning that it also crosses the glenohumeral joint. And in that sense, we know that a muscle that helps to interact with the glenohumeral joint that works on the posterior side of the body, we already can kind of figure out what that does. And we know that that much the same way that the biceps helps to both flex the elbow and the shoulder, the triceps, at least the long head, helps to extend both the elbow and perform shoulder extension as well. And then the only other muscle that we're going to be talking about for today's lecture in terms of the elbow extensors is this teeny tiny little muscle here called the anconeus. And yes, it does perform elbow extension. As we can see, the size of this muscle compared to the size of the tricep, a little bit different here. So of course, we once again have this really nice little synergist right here. But the anconeus actually has another little job, and that is essentially locking your elbow out. once the triceps are contracted too much, once our elbow gets just too far extended, the triceps don't have that same kind of mechanical advantage to be able to pull the olecranon process actually into the olecranon fossa. Or again, we're all kind of three-dimensional, well, not kind of, we are all three-dimensional beings, so we have the, we sometimes as our bones are rotating, we kind of need a little bit of extra help to allow everything to lock into place. And that's where the anconeus comes into play. We get as far with the elbow extension as we possibly can from the triceps, and then the anconeus takes over just for like the last degree or two, depending on how mobile your elbow is, just to kind of lock that olecranon process into place into the olecranon fossa. Now, for people with that cubital recurvatum, or that elbow hyperextension, as it might be called, that is that's going to be something that is much more the anconeus is much more active in helping to get the olecranon process all the way into that deeper fossa, because again, it is you have a little bit extra range of motion there. So usually people have hopefully just stronger anconeus muscles if you have elbow hyperextension, but sometimes it also does happen where they end up getting this muscle being irritated because it's having to work harder than this tiny little muscle is capable of performing. So it actually is quite an important muscle, especially for, once again, getting our elbow fully locked out and getting all that really nice stability that we can get when our elbow gets locked out. So the anconeus is really active and really important in doing that. And again, when it comes to the elbow, we're going to talk next week about the arms, the muscles of the arm and hand, the wrist and hand, excuse me. And we're going to see once again that muscles will cross several joints and will attach onto certain aspects of this of the elbow. And if it is on the posterior side, which of course many of these muscles will be, as we'll talk about, it will help to perform elbow extension as well. But because those muscles we'll be talking about next week, I didn't include them here. So the main movers that we have in the elbow joint specifically for extension would be the triceps brachii and the anconeus. And that's about it. So when we take a look at this right here, we want to think about different ways that we can actually kind of help to protect the UCL. Now, I'll give you this piece of information right here. What we've seen is that weak rotator cuffs, weak rotator cuff muscles, really do allow for an increased risk of the UCL. And what you can kind of see is, especially with this style of pitcher, this is like a sidearm pitcher, so they might be a little bit more susceptible to that, although I'm not exactly sure that that's in the research that's a riskier pitching motion. But whatever the case may be, you can see that at least this pitcher right here, as we've already seen a picture of, he is definitely at much more of a risk of that kind of injury, right? So when we take a look at this, what we're seeing is you can see the ripples in his shirt just as it's kind of rotating around his armpit, right? You are supposed to be able to get an insane amount of external rotation to be able to get these pitches off. We're going to take a look at pitching motions later on in the semester, as we've been taking a look at kind of throughout. We're going to take a look at more pitching motions and be able to see that pitchers get this really crazy level of external rotation. So in order to be able to help out with that, right, we need to have really flexible muscles that perform internal rotation, which, if we're talking about the rotator cuff specifically, remember that was the subscapularis that was able to do the internal rotation of the shoulder. So we need really flexible muscles there, but we also need to make sure that our external rotators, our infraspinatus, nominally our supraspinatus, but then our infraspinatus and our teres minor, those muscles are really important to be able to help kind of pull him into that position. So this question might be better written as, why would weak/inflexible rotator cuff muscles put more strain on the UCL? And it's because if he can't get his humerus as far into external rotation as he would need to be able to do, then his elbow kind of needs to make up for that. And that's where we see like a pitching motion like this, where he gets a lot of elbow valgus because he needs to get his arm back there so he can get that nice whipping motion to be able to throw the ball forward very quickly. But if he doesn't have that range of motion in his shoulder, or if he doesn't have the strength to help stabilize the shoulder joint and pull it into external rotation, then we don't necessarily get that same range of motion in the shoulder, and our elbow has to make up for it. So that's kind of why we have the UCL being at a little bit more of a risk with people with, again, either weak external rotators and or tight internal rotators. So again, we think about that. We think about the external rotation actions that we were doing, right? You know, we were talking about this last week, and, you know, especially here at 90 degrees, you see a lot of baseball pitchers kind of doing this, even though the motion is, of course, moving forward, doing a lot of the external rotation, especially at 90 degrees of abduction. We get a lot of those particular motions that kind of happen all the time as well, right? So we can do that and really strengthen that, and then you can do, you know, some external rotation stretches, maybe get like you know, if they're there on a baseball field, maybe they get a baseball bat, kind of pull their arm into that external rotation a little bit, which would help to stretch out the subscapularis and the rest of the internal rotators. So really looking at something like this, right, we can see that, you know, again, this is not a sports injuries class, so we're not going to get too much into it in this class, but, you know, we can really see that something like an injury to the UCL, while yes, we would really rather have some really nice strong forearm muscles to help kind of prevent this as well, but what we really take a look at is that maybe the issue has nothing to do with the elbow. Maybe the issue has to do with your shoulder joint and your rotator cuff specifically. So that just kind of goes to show that, you know, injuries and aches and pains and injury risks and all these sorts of things don't necessarily, you know, always have to do with the joint that's in question. And it could be, thanks to that kinetic chain that we've talked about throughout the class, it could be a result of something that's happening somewhere else in the body. So again, depending on which profession you might be going into, think about different ways that you might be able to kind of utilize this sort of knowledge if you're going into physical therapy or personal training or athletic training or occupational therapy, because we're talking about the arms, right? Like you will be able to kind of apply this knowledge and make sure that you're getting everything the right way and analyzing everything the way that you need to. So moving on from there, I am going to switch now to the forearms. So obviously you can feel free to pause this video at any point, but this would be the time that if we were in class, I would, you know, give everybody a few minutes of a break. Maybe it's not a bad idea to get up, walk around, do some things, come back to the video, but whatever the case is, I don't have to do that because you guys can just pause, so I'm just going to move right on. Now what we're going to do is we're going to talk about the forearms, right? And once again, when we talk about the forearms, much the same way as the elbow, if we're talking specifically about just the localized parts that are interacting specifically with the forearms, there aren't very many of those to kind of go on, right? Once again, when we think about the forearm muscles, right, all those muscles that we talk about here, if you move your fingers around, you'll see that, you know, all those muscles control the fingers. So we're going to talk about those next week because those muscles are usually named for the joint, the most distal joint that they control. So that's why we're not really bringing those up right now. But we are going to talk about the anatomy of the forearm specifically and a few of the muscles that do help it to work. So the forearm, really, it consists of two bones itself. We have, as we've talked about already, we have the radius and the ulna. And as I mentioned earlier in this video, you take a look at the radius and the ulna, and you can see that the ulna, for example, is really thick and really large up at the proximal end, or the top of this picture, and it's really small, or comparatively small, down at the distal end, right? And then the exact opposite is true for the radius. So we see the proximal end of the radius is that kind of small area, and then we see the really large articular surfaces that we have down at the distal area. So you can almost kind of think about these as very similar bones that just, you know, one happened to be flipped up on its end. It's kind of what it always seemed like to me. When we think about the joints of these two things, we can see, if you look at the 1, 2, 3, 4, the fifth word down on the left-hand side of this picture, we see the tuberosity of the radius, or the radial tuberosity is how I would typically refer to that, but you can say it either way, right? You can kind of see the way that kind of point sticks out right there. And on the and what it does is it articulates with an articular surface on the ulna. Right, and what that does is we have one of those on the proximal end. We have that articulation down there. We also have a similar thing. You can kind of see the way that the bones kind of come back and they once again touch one another down at the distal end as well. And what that does is it allows for this kind of allows for this kind of rotation to happen, you know, on the side. So they kind of are able to kind of rotate around one another on either side. So we know these as kind of pivot joints, which allow us to be able to kind of flip our forearm, or flip our hand, I should say, upward or downward, right? And we'll talk about what those motions mean here just in a second. But that motion is not because of our wrist, it's not because of our elbow, it's because of the proximal and the distal radial ulnar joints. That's what allows us to perform those two motions. And the names of those two motions are what we call supination and pronation, right? I've always kind of thought about it as like supination is kind of holding a bowl of soup. That's always kind of helped me. But I also played a lot of Call of Duty when I was a kid, so whenever I think about like prone, you know, when you're playing those games, you had your character kind of lay face down. So I don't know. To me, that always made sense too. Is that, you know, prone is face down, supination's face up. Whatever the case is, however you want to be able to remember it. But we do have, if we're talking about, you know, supination and pronation, if you think about yourself in the anatomical position, you are really neutral, but you know, your hand, you would kind of consider your palm to be within supination, right? Because your palm is kind of facing out in front of you, so that's kind of a supinated position, especially when you kind of hold your hand up like this. So we have that particular motion. If we turn our palms to face behind us, right here, turn our palms to face behind us, now our hands are in pronation. Right, so we can kind of think about that and all the different planes that it might be able to go, depending on, of course, the positions of the rest of our joints. So when we think about the forearm muscles, right, you know, usually we think about all these different muscles. You can see all the tendons running down to the hand. I think I might have mentioned once or twice already that we're going to be talking about this in the next slide or the next week. So I don't think I need to continue to let you guys know about that. But what you're actually looking at here, they are not forearm muscles, what we're taking a look at. These are real muscles that, again, you know, kind of control the wrist and the hand. So when we take a look at the muscles themselves that only work for the forearm, or at least mainly work for the forearm, we only look at the two motions that the forearm itself is specifically able to do, and that's pronation and supination. So right here, we have the two muscles that perform pronation, and I don't think there's any secret as to how they're named how they are, the pronator teres and the pronator quadratus. The pronators perform pronation, go figure, right? And then the only difference here is the pronator teres is kind of shaped like a triangle. That's, you know, the name teres that kind of looks right there. And then we also have the pronator quadratus, which, as you can see, is more of a square, right? It's a kind of a quadrilateral. So we have those two different things. One thing that I wanted to point out here is if we look at the pronator quadratus first, you notice that the origin is on the ulna, the insertion is on the radius, and that's all it does. It does not cross over any other joints. Really, it crosses over mainly the distal radial ulnar joint. So that's the, you know, kind of the main one that it controls. Because there is, you know, just these two joints on these two bones, it's not only going to control the distal, it will control both radial ulnar joints, but it kind of runs over the distal one, so we think about it in that sense. But when we take a look at the pronator teres, now what we can see is that the origin point, once again, look at where it is. It now sits on the elbow, right? It crosses over the elbow, and it sits on the humerus. So now when it sits on the humerus, we take a look at that and we say, okay, a muscle that sits on the anterior side of the humerus. All right, we know, of course, just the way that it runs. We can see the direction of the pull that it has and everything. It's going to kind of pull the lateral surface of the radius, as you can see on the insertion point there. It's going to try to pull that closer to the medial part of the humerus. That allows us to be able to perform that pronation type movement. You know, when it kind of sits right there and it contracts, it's going to pull the hand over. But once again, when a muscle sits on the anterior side of the elbow and does technically cross the elbow, we know also that that muscle is going to help with elbow flexion. So that's also a really important point to kind of take a look at there. On the other side, we have an even simpler name muscle. The supination muscle is called the supinator. Very easy, right? So when we take a look at that, now we can once again see that we have again, these pictures are in 2 dimensions. So it's not exactly the greatest representation of these things, but we of course know that we're 3-dimensional humans. So as these muscles kind of wrap around the bones, as they pull, they're going to cause that rotation to be able to occur. But what we also see is that once again, it sits up on the humerus. So it crosses the elbow joint. Now it does so on the posterior end. So not only does this muscle perform supination, but it also helps to perform elbow extension. So I just like to kind of talk about that as well. But we get to one other muscle in the forearm that we've already seen in this lecture today, and that is the biceps. you can see as the biceps gets, as it moves more distally, it of course crosses the elbow joint, as we've seen. We know that it does shoulder flexion because it crosses the glenohumeral joint. We know that it does elbow flexion because it crosses the elbow joint on the anterior side. But then we can also see that the that part of the biceps tendon that attaches down onto distal to the elbow attaches right onto that radial tuberosity. And because it attaches onto that radial tuberosity, what you're actually able to do as well is perform that same supination, right? So when you are performing a bicep curl, if you were to kind of start, I'm trying to do this while I'm sitting down in front of a really small camera here, but if you were to perform that, a full biceps contraction might also come from going from pronation into supination as well, right? And as we've talked about before, we've talked about the way that certain muscles and certain antagonists and stuff like that are able to kind of like block out other motions. This is a really great example of when we might need to do that, right? If we're doing a bicep contraction and we're trying to do like a hammer curl, right? Our biceps want to, as they're shortening, our biceps want to supinate our hand. They want to try to turn our hand over. So if we're able to do this, what we're also doing is contracting our pronator muscles to kind of help them play a tug of war with that particular motion of the biceps, so that we don't get into supination. Our pronators are working at the same time, so they kind of cancel out the supination aspect of the biceps brachii, right? So we get, if the full motion that happens there allows us to be able to do a few different motions, supination being one of them. But if you kind of take a look at the elbow, or you take a look at the biceps, if I turn my hand over, you can see how much the bicep stretches out versus how much it kind of shortens right there, right? So you can kind of see, the length change of the elbow as that, of the bicep, as we're moving from pronation to supination. So we don't, we do see that the bicep really wants to do the supination, but if we need a good amount of supination, our biceps will absolutely click on, and they will also assist with the biceps motion, with the supination as well. Oops. So that's why, again, I shouldn't even put the slide in here with the amount that I've mentioned this already, but that's why when we take a look at everything else, right, that's it for the forearm. We talk about pronation and supination, and that's about it, right? So whenever anybody talks about the forearm muscles, like, you see in this picture right here, this is the first picture I found when I Googled forearm muscles, right? So, when we think about that, we think about the muscles that are involved within the forearm itself, right? When we move our hands and we flex our wrists and everything, we see the forearm muscles contracting. And that's why we always kind of call them that. But we're going to talk about these next week because they do cross over all those joints, and that really does mean that we're going to have a lot more discussion to be able to do about it then. So, as is usually the case in pretty much all parts of the body, and we definitely saw this in the shoulder, it's a little bit difficult to kind of classify these muscles as elbow muscles or as forearm muscles or as wrist and hand muscles. So I did my best to try to divide this up to make these lectures as equally long as possible, or equally short as possible. But I also wanted to make sure that we were trying our best to classify these in the best anatomical ways. So we'll talk more about that stuff next week, but that's going to be the end of the lecture for today. If you guys have any questions, again, you're more than welcome to shoot me an email. Let me know what's going on. You are watching, if everything is going the way that that was planned, you should be watching this video at the latest. Let me see what day that is. You should be watching this video at the latest on October 30th, right? So that is that's the day that we kind of have these things planned. So if you have any questions, please just let me know. But next week, which would be the 6th, we are going to be doing another online lecture. That one will be the wrist and hand. That is going to be in this exact same format. So once again, take a look at that. Let me know if you have any questions, and I will see you guys in a few weeks. Have a good one.